in about 50% of the patients, there are these really gorgeous, beautiful, gigantic giant cells in there. There is a category which we call the biopsy-negative GCA patient. That patient is usually diagnosed with typical finding by imaging, and as I already mentioned to you, the thrive is that we can move this to making this an imaging diagnosis. However, right now, there is nothing as valuable as having a tissue biopsy. Rarely, the tissue biopsy is collected during surgery. Again, I already mentioned that to you. It comes very often unexpectedly that the surgeons come to us and say, listen, we have a case here. What about blood tests? Can we draw a blood test and tell you whether you have giant cell arteritis? There is that highly elevated sedimentation rate or the C-reactive protein. They are helpful to us, but they are not proof of diagnosis. Actually, as valuable as they are for us, they also create problems for us because they are non-specific and they force us to face the question, is the patient actually having active disease or not? This is what the biopsy looks like. You don't need to be much of a pathologist to actually recognize that something is going wrong. This is what the artery should look like. It has obviously a hole in the middle where the blood flows. And you see when the patient has vasculitis, that hole is occluded. No blood can flow. I don't need to give you much explanation that this is not a good scenario for that patient. So when the tissue biopsy is harvested and the diagnosis is made, how do we treat GCA? The golden standard of therapy is prednisone, the drug that you're all nervous about, I know. We call it cortisone or glucocorticoids or corticosteroids, etc. I can tell you, it will be hard to beat this drug in treating this disease. It treats GCA promptly and effectively. It's initially given in high doses, it's then tapered, and it may be discontinued if the physician and you come to the conclusion that the disease is sufficiently controlled. Remember, we did not invent prednisone or the corticosteroids or the steroids. Nature invented it. This is nature's preferred and primary and most effective way of suppressing inflammatory immune responses. So there's something about it that must be good. Of course, we are always looking for steroid-sparing agents. We do tell our patients that they should be on aspirin. Actually, aspirin may even do more than that little blood thinning that we all look for. You know that Dr. Merkel has worked on trying to find out whether methotrexate works in this disease. There may be some mild benefit from it. There is no benefit that we know of from anti-TNF therapy, so we really rely on the golden standard. I think our biggest hurdle in moving the treatment for this disease is the fact that many of our patients are older. They are older than 50. Many are older than 70, and you've got to be very careful when you take an immune system that's 70 years old and you suppress it, because it's 70 years old. It doesn't want to be suppressed. There is not much left in that immune system to suppress. So I tell my residents, my fellows, if I make it to 85 and I get giant cell arteritis, give me my prednisone and leave me alone. So what is the short and the long-term prognosis of the disease? Actually, the overall prognosis of the disease is very good. We do not have evidence that the life expectancy of patients is shortened. There are data coming from Scandinavia that actually indicate that patients who get this disease may live longer than those that do not. So this may be an indirect evidence that to get this disease, you have to be rather young at the age of being 75. What are the difficult issues? The difficult issues is the vision loss. This is a disease that causes what we think is preventable vision loss. There is nothing as devastating coming into the life of a human being than losing vision in an eye when it could have been saved. So that determines, and the fear of further vision loss, of course, encourages that we overtreat this disease. Because when in doubt, we will treat. Because we don't want to come to that point that we're losing vision in the second eye. The long-term use of steroids is not an uncomplicated issue. You're all very familiar with this, I know. There is hypertension, weight gain, diabetes, thinning of the skin, reduced muscle strength, impaired immune responses. However, again, this is an old drug. We have had it for about 65 years. We know everything about it. There's nothing hidden in the closet. There's not going to be a report tomorrow that we're seeing a new side effect from corticosteroids. We know them all. This is an old drug, well known to us. It's nature's preferred way of downregulating inflammation. And remember, all medications have side effects, particularly in individuals that are older. And I think it would be critically important for us that we find better ways to make a decision when the patient should be treated, because we can apply therapy very well, but our issue is, does that patient need therapy or not? That is the critical question. Why do people get GCA? Of course, if we knew that. Just if I could give you one sentence answer to this question, right, we would probably not be here, those of us interested in GCA. Okay, now, number one, the immune system of these patients is dysfunctional. This is an immune system-mediated disease. The white blood cells attack the walls of arteries. When you go in there, that artery is filled with white blood cells of the immune system. We know by now that there are at least 2 types of activated white blood cells that contribute to the disease. One type is called Th17 cell, and you will hear about these cells. And they respond very well to therapy. And there is another type, they are called Th1 cells. By the way, the Th1s are older than the Th17s. You hear that from the numbering, right? And they are relatively resistant to therapy. That's an issue for us. That makes it difficult, because if we could stamp them out, I think we would be in much better shape. The immunologists today, when they talk about the immune system, talk about that there is an innate and an adaptive immune system. The innate is that we all share, that's all very similar in us. The adaptive is that immune system that each of us creates, adapted to our needs and our immunological experiences. We by now know that both of these immune systems play a role in the disease. They may actually be both pretty good in these patients, and that may be the reason that people get this disease at an older age, when the immune system usually kind of loses efficiencies. The patient's immune system, when we look at it, looks as if it is fighting an infectious organism. Actually, I should go a step further. I should say that the last year, we're beginning to think that there may be more than one organism. There may be 2. And that, of course, would make it even more challenging, but that may explain to us why we are fighting with 2 enemies, and we have to keep that in mind. The future has to look and try to design therapies that can reset the immune system, not just suppress it. I don't think that we can win this by just going in and destroying immune systems. We have to make the immune system better. We have to teach it to not make these mistakes. Now, it's not alone the immune system. The blood vessels have their contribution too. They are a partner in crime. How do we know? Now, have you ever wondered why any doctor in the world wants your blood vessels from your temples? I mean, we barely know we have a blood vessel there. It's a pretty strange place to have a disease, right? We now know that human arteries can actually sense infections. Why they do that, we do not know exactly. Why did nature actually select blood vessels to help us to sniff infections and see whether an infection is going on in our body? But the cells that the arteries use to sense infections are responsible for starting vasculitis. This we know. And so the big question is here, is vasculitis a reaction to an infection? I'll leave that question with you. Trust me, the community of researchers has had that questions for a while. And I would say there are ups and downs in the answer to it. And there is evidence that there may be a very close relationship between having an infection and getting this disease. Arteries in different parts of the body handle infections differently, and that is probably the reason why you get these vasculitides in the very strange places and why some of these diseases, and in some patients, goes to place A and not to place B or to place C. Now, we use that information, of course, to actually make the diagnosis, as you all know, because when we see which blood vessel is affected, we have an idea. Okay, here a little bit an outlook. At Stanford, we always have to be at the cutting edge of things, right? We have to drive it. It has to move. We Californians have to run the bus, right? So here is a model where we actually take human arteries and we put them into a mouse that has by itself no immune system. And then we have a human blood vessel in a mouse, and then we can transfer the human immune cells into that mouse. And for the first time ever, we have the opportunity to actually watch how the immune system and blood vessels talk to each other. So in that test system, by the way, if you come to our vasculitis clinic, we may give you a special mouse because we will certainly want to test whether your cells are still in the mood of attacking blood vessels. And